Mr. Ashwin.
Okay.
So, sir, it's 3, 2, 1. We are live now, sir. Over to you.
Good afternoon to all the doctors. On behalf of Macleods Pharmaceuticals, I, Ashwin Kotankar, welcome you all for this today's session on revisiting the treatment strategy for renal-compromised diabetics. On this topic, we have with us Dr. Vinod Mittal. Before we start today's event, I would like to introduce Sir. Sir is a senior consultant and diabetologist and head Center for Diabetes and Metabolic Diseases. Sir is the director for Delhi Diabetes Care Center, New Delhi, and advisor and past chairman for RSSDI, Delhi, and regional faculty for CCEBDM. And Sir has did his graduation and post-graduation from Maulana Azad Medical College, New Delhi, and fellowship from American College of Physicians, RSSDI, Diabetes India, and ICP. Sir did his masterclass in diabetes management from Royal College of Physicians, UK, and postgraduate program in diabetes from John Hopkins Institute. And Sir did his PG diploma in diabetes management from Middlesex University, London. Sir is having a vast experience of more than 32 years in the field of diabetes and received many honorary awards at various international platforms, national and international platforms, and National Award for Excellence in Diabetes Care in 2018 during RSSDI, Diabetes Awareness Initiative Award in 2017 by Diabetes India, and Dr. Sarita Bajaj Oration 2019 at Cardiac.com. These are the few awards from the huge list of awards Sir has received. And Sir is a regular invited speaker in key national and international conferences and principal investigator in several research projects and clinical trials. On behalf of Macleods Pharmaceuticals, I welcome you, sir, for this today's program, and I request you to please take over the session.
Yeah, thank you, Dr. Ashwin, and it's my proud privilege to be here to share my knowledge on linagliptin, especially in renal-compromised diabetic patients. So, and I welcome all my esteemed colleagues, doctors, and friends and seniors. And I would be very happy at the end of the session, we have a good discussion. Just let me share my screen.
Yes, sir, you can share your screen.
Yeah, is it okay? Can you see this?
Yes, sir. It is visible.
Yes, perfectly visible.
So, as I mentioned, I would be discussing basically about linagliptin, various CVOTs, and especially its role in renal-compromised diabetic patients. And overall, we all know the burden of diabetes world over, and there are currently, nearly 550 million cases. And it is approximately 10.5% of world's population. That means, overall prevalence is very high. It varies from different countries to a different country. And this is an ongoing process. There's a fast explosion in the recent past. And like it is an ever-growing problem, and it is a big menace to manage this growing epidemic of diabetes, obesity, and cardiovascular disease. So overall, we see again, this is different, countries which have different, prevalences of diabetes, and like India is not way behind. And India also, we have different prevalence in different states. Like it's more in southern part of India and some northern, states like Punjab, etc. India accounts for almost, 1 in 7 of total diabetic burden of the world. And overall, today in China is having the maximum number of patients, and followed by India and then Pakistan. Pakistan was never in the list, in first 10 even, and it has come up so fast. So the population of Pakistan is very less, as compared to India. So that means, overall highest prevalence of diabetes in the world is in Pakistan. And like overall, we see the number, then it is in China, followed by India. And India, as there is a gradual growing of number of cases, we can see in 2045, the difference between China and India would be less, although India would still projected to be number 2. And like it is also known that if we have a good control on A1C right from day one, intensive glycemic control has been seen in DCCT and in UKPDS in type 2 diabetic patients. There is approximately, overall, if we see there is 30 to 35% reduction in microvascular complications. And in macrovascular complications, the difference is very less. But the important point is if we have a good control in the initial stage of diabetes and continue to keep the same control throughout the life, then definitely there would be a huge reduction in type 2, like in CVD in type 2 diabetic patients. Now, this is a famous ominous octet. Everybody knows there are almost 8 defects. In fact, there are almost 13 or 14 defects, pathophysiological defects in the causation of type 2 diabetes. And the most important of these are incretin defect, which is taken care by GLP-1. So if we take into consideration, so GLP-1 and DPP-4 take care of this incretin defect. And then, insulin sensitivities by thiazolidinediones, primarily even by DPP-4 inhibitors. Then renal, is by SGLT2 inhibitors. Then muscle sensitivity, again by thiazolidinediones, by insulin sensitizer, and hepatic glucose output, mainly by metformin, but also by DPP-4. So overall, if we see DPP-4 have multivariate and, multiple effects which address all these pathophysiological defects in type 2 diabetes. For example, incretin defect also would be taken care of. Then some part of insulin sensitivity in muscles and fat, then liver, and most important is there is release of insulin in a dose in a glucose dependent manner from the pancreas. So that's another important effect, and they're weight neutral. Now, when we take food, it gets digested, gets absorbed as glucose, and there is release of insulin from beta cells in response to increase in glucose in the blood, and there is also a suppression of glucagon at that point of time. But in type 2 diabetes, there is less of insulin release and there's more of glucagon. So both these defects are taken care by DPP-4 inhibitors. Actually, DPP-4 enzyme metabolizes, or rather catabolizes, active GLP-1, which is an incretin released from small intestine, and which is the main, basically active chemical or hormone which releases insulin from the pancreas. There's some rejuvenation of beta cells also, and there is basically a suppression of glucagon. So these are effective, effects of GLP-1. But it is getting metabolized by DPP-4 enzyme. So we give DPP-4 inhibitors to keep active GLP-1 for a longer time, so that doesn't get metabolized, and it has its effects for a longer time in type 2 diabetic patients. So that's how DPP-4 inhibitors act. Now, diabetic kidney disease again is very common. The only problem is we come to know only when patient comes and tells, either there's a decrease in urine output or serum creatinine by just a chance finding goes up, or patient goes for dialysis, etc. But that's wrong. If we start screening type 2 diabetic patients at the onset of type 2 diabetes, the diagnosis, and by eGFR and by finding out UACR. So it is a must now to do UACR, urine albumin creatinine ratio, as well as eGFR in all type 2 diabetic patients at the time of diagnosis. And take my words, it'll be much more than 40%, patients who either have microalbuminuria or there would be some small compromisation of eGFR. Although in stage 1, there is hyperfiltration and there's increase in eGFR. So diabetic kidney disease is, again rising at an alarming rate. And there are, established markers for type 2 diabetes, or the risk factors, rather, we should say, in type 1 and type 2. And these are basically, if we see, like there's certain established one, like say glucose levels like HbA1c, blood pressure, albuminuria, eGFR, duration of diabetes, micro complications, especially retinopathy, then family history, age, and uric acid. So these are known. And there's certain, which are like only in type 2, but not in type 1. These are like male preponderance. Males are more affected and they have more chances of having diabetic kidney disease. Then ankle brachial index is another important, parameter or a marker, which, again, if it is abnormal, there would be more of renal compromisation. Then late consequences of kidney damages. In fact, when we all know there is reduction in hemoglobin because erythropoietin is being synthesized by the renal cortex. And if there's no, synthesis of erythropoietin, there would be anemia. And so we have to supplement erythropoietin from outside, like other hormones. So there is decreased hemoglobin. There is also compromisation because 125 dihydroxylation happens only in the kidney. 25 hydroxylation of vitamin D happens in liver. So once renal compromisation is there, again, basically there would be. So these are a couple of things which are important in a patient who has diabetic kidney disease. And then obviously there are a couple of more things which are important, and these are actually, besides, glucose levels, and these are smoking, then obesity and dyslipidemia. So we have to have a multifactorial approach in managing type 2 diabetic patients with diabetic kidney disease. And it is not only control of glycemia, it is stopping or smoking, as well as control of weight, blood pressure, as well as dyslipidemia and other factors. So here we can see that if we, urine albumin excretion rate, if we see, here we can see this is eGFR. So initially, as there is a decrease in eGFR, there is increase in albuminuria, and there is a progressive diabetic kidney disease. So that's an important thing we have to understand. And we all must be knowing that, this is A2, that is 30 to 300 is microalbuminuria. So less than 30 is normoalbuminuria, 30 to 300, and more than 300 is macroalbuminuria. So this is an important thing. So as there's a progression of diabetes and kidney disease, there is a increase in albuminuria also, and which DPP-4 inhibitors have shown to reduce this albuminuria. Although it is not 100% marker for kidney disease, there are a number of patients who have kidney disease without albuminuria. But if patient has albuminuria and there's a progression of albuminuria, then definitely there is a progression of diabetic kidney disease. And as the diabetic kidney disease progresses, there is a gradual decline in eGFR, which as we grow old, also there is a decrease in eGFR, almost 0.5 to 1 ml per year. But if patient has a diabetes and diabetic kidney disease, the progression is very fast. It is almost 0.5 or 0.75 ml per month. So in a year, it is almost 8 to 10 ml. Now, this is the ADA 2020 guidelines for the treatment or management of type 2 diabetes. Lifestyle modifications always remain the main cornerstone of management. We should always focus and endorse and make patient, try to motivate the patient to abide and follow lifestyle modifications, although very difficult. So, but, if we keep on, endorsing and keep on motivating the patient, a lot of patients still, they understand. After that, yes, definitely, we have to straight away start with medications. Metformin remain the first line. But as, with ADA 2020 guidelines, it is not that we have a stepwise approach. It is an intensive combination. So initial stage only, we can start with dual or triple drug combination on day one, or maybe insulin, depending on the patient's characteristics. So that I will not go into detail. You must be knowing that. But the only thing is that along with lifestyle modification, it's not that only metformin first and then. So you can give a combination also. Now, here we can see, if we see talk of today, our focus is on DPP-4 inhibitors, especially linagliptin. And here we can see that DPP-4 inhibitors, they have three discrete advantages. One is hardly any hypoglycemia. Then they are weight neutral. And thirdly, there are hardly any adverse effects, no adverse effects, no if and buts. And obviously, the cost used to be high, but now with the availability of good molecules, good companies and generics, we have the cost is also kind of can be tackled. But I would like to convey one thing, that all generics are not same, so we should go by companies which have a good, R&D backup, so that we are sure of the quality of the medicine we are prescribing. So overall, so after metformin, like DPP-4 inhibitors have a place, in almost most of the patients of type 2 diabetes. And like coming to, if we talk of Lina, and so there is an extensive, binding to DPP-4 receptors, and these are to S1, S2, S1, dash and S2 dash subsites. So extensive, binding. So that makes, it's like the longer duration of, a DPP-4 enzyme, DPP-4 or GLP-1 incretin would remain for a longer time, or inhibition would be there for a longer time. The extensive binding would result in more, or prolonged DPP-4 inhibition. So metabolism for Lina is undergoes minimal metabolism. 90% of drug remains unchanged. And bioavailability is, although 30%, but it reaches maximum concentration in 1.5 hours. And overall, it is like T half is 12 hours. So the duration of effect remains for 24 hours. So it's a 24-hour effective medication. Dose is only one dose in all stages of diabetes, and as well as kidney disease, 5 milligram OD, irrespective of EGFR. Although, all DPP-4 inhibitors are safe in kidney disease, but there's a dose modification. Like for sexagliptin, elogliptin, sitagliptin, we have to, adjust the dose. But for linagliptin, there's no adjustment. It remains the same. Now, then if we see the different trials, we have now so many trials with the GLP-1 analogs, with DPP-4 inhibitors, with SGLT2 inhibitors. Now, coming to DPP-4 inhibitors, coming to heart failure, we have only, basically sitagliptin and linagliptin are, say safe in heart failure, because sexagliptin in SAVOR-TIMI 58 showed there was an increase in hospitalization due to heart failure by 27%. And then coming to, harmful effects, yeah, it's there below. So sexagliptin as well as elogliptin, they had a increased in hospitalization due to heart failure. Yes, rosiglitazone story everybody knows. It was banned also. And then even pioglitazone, there are concerns stage 3, NYHA class 3 onward, we should not be using pioglitazone, because there's a water retention and there would be more chances of precipitation of heart failure. Now we have many studies. Linagliptin is an extensively, studied molecule, and they are, non-inferiority trial with glimepiride in terms of A1C reduction. So overall A1C reduction versus glimepiride was found to be the same, although with the, sulfonylureas, there is an initial rapid dip in HbA1c, but slowly there is a catch-up with linagliptin. And overall, there is a sustainability with linagliptin. At the end of, say, almost 2 years, linagliptin was found to be better, slightly better in terms of A1C reduction, in terms of sustainability of the effect compared to glimepiride. Now, here we can see again 2 years of data, and we can see, the effectivity is almost the same, A1C reduction with both the molecules. In fact, sustainability, if we talk, is more with linagliptin compared to glimepiride. And hypoglycemia, I think we do, like, there's nothing, new in this. We all know sulfonylureas have the maximum along with insulin, risk of hypoglycemia, and DPP4 hardly. So we can see the difference. It's almost 5 times. So 1/5 the chances of hypoglycemia. In fact, it is much less. Then cardiovascular events are also, if we see in this study where Lina was compared with glimepiride, like it is more in favor of glimepiride, like CV death, then non-MI, fatal MI, non-fatal stroke. So we can see here, like this is in favor of linagliptin. Then kidney disease, if we see pooled analysis, again, 5,000, nearly 466 patients. And here we can see the new onset of albuminuria and macroalbuminuria, worsening of CKD. These were the, basically primary composite endpoints. And we can see here very clearly again in favor of linagliptin, whether irrespective of age. Age is an important point to remember. And like it is, whenever we start a medicine, say whether it is metformin or sulfonylurea or insulin, we have to decrease the dose. We have to be very careful, in elderly population because of the side effects, where and other, efficacy also. So here, linagliptin was found to be like the effect, same favorable effect in kidney patients with irrespective of the age, then irrespective of the ethnicity, and as well as irrespective of the use of ACE or ARBs. ACE ARBs are very commonly used to prevent the progression of diabetic kidney disease. But last 15 years, there was no other medication except now, now we have SGLT2 inhibitors and also, DPP4 inhibitors, linagliptin and other gliptins have shown to reduce albuminuria in these patients. Then like this slide, is showing basically a reduction in albuminuria with linagliptin. I think this is a known fact. And that shows that and it is in addition to, on the top of RAS inhibitors, ACE or ARBs. It is not that, like whatever has already been achieved with the help of ACE ARBs, on the top of that, if we add linagliptin, there's further protection of renal disease. Then long-term efficacy, safety has been found in patients who are severely compromised, renally compromised in this study, as well as we have another study, CARMELINA. So it has been very well documented that even stage 4 and 5, in fact, patients who are in stage 5, that is patients having ESRD and on dialysis, DPP4 inhibitors are the only safest, agents available. Even insulin can lead to hypoglycemia there, and all other oral or other agents, are relatively contraindicated or a very small doses to be given. So this is a slide showing a very clear, reduction versus placebo. Linagliptin is very effective, almost 0.8% reduction in A1C. And then at the end of 52 weeks, the same slide, versus placebo, the very good effect, 0.7 to 0.8%. Now, this is another study where linagliptin was studied in patients who were having age more than 70 years and were inadequately controlled on other anti-diabetic agents. So when linagliptin was added in these people more than 70 years, we can see the difference. This is a placebo, means already the standard treatment, and this is an intervention arm when linagliptin was added, and we can see nearly 0.6 additional reduction in HbA1c. Overall hypoglycemia, needless to say, it is much less with DPP4 inhibitors. And then overall, like if we see the weight, generally there's a weight gain with the sulfonylureas, and there is a weight neutrality with linagliptin. But along with metformin, if we see there is a reduction in weight with lina plus metformin. And while there is a small gain in weight when we use glimepiride with metformin. Now coming to effect on glucose metabolism and islet cell function, vascular function, we can see here that linagliptin, there is reduction in HbA1c, fasting, postprandial, even glucagon suppression. No other oral anti-diabetic agents, it suppresses glucagon, except GLP-1, which is generally available as injectable. So, and they are very costly. Basically, there is improvement in incretin levels, suppression of glucagon, better insulin levels, and there's also decrease in proinsulin, which is a kind of an impurity and has side effects. And then also there's reduction in say procoagulant marker, that is PAI1. Then cardiovascular safety, we see again, there is linagliptin, we can see there's no increase in cardiovascular events versus comparator, and there's no increase in hospitalization due to heart failure. Now, this is a study which was, basically done in animals, but it is only indirectly, evidence that it may be possible in humans also. That linagliptin, it improves or increases endothelial progenitor cells and anti-inflammatory monocytes in animal studies. So that makes it a really, very good renoprotective agent. And there is, inhibition of formation or thickening of basement membrane and formation of matrix and other things, So once we have these endothelial progenitor cells increase and anti-inflammatory, there would be less damage to renal parenchyma and endothelial cells of the glomeruli. So this is an important thing to understand. And we have two important studies with the linagliptin. We have CARMELINA and we have CAROLINA, and more than 13,000 patients. In CARMELINA, there were very high-risk patients who were having cardiovascular disease, renal compromised patients, as well as some patients had history of heart failure. Now, there were high proportion of patients, if we see in CARMELINA trial, 62.3% of the patients, they had basically, renal compromisation, while in SAVATIMI, it was only 15%, EXAMINE, it was 29, and TCOS, it was 9.3. So there was another important point in this trial that patients were having long duration of diabetes, obviously, since they had, renally compromised and cardiovascular disease also. So it's a long duration of diabetes. Almost 60% had established cardiovascular disease. 27% had previous history of heart failure. And 75% nearly had a history of, having a kidney disease, diabetic kidney disease in some form or the other. Of different grades of severity. And 58% of these patients were on insulin, means more patients on insulin because they were renally compromised patients, and only 55% patients on metformin, because generally we see the trials, we avoid renally compromised patients to be included, and they're generally excluded in the trials. So metformin is generally used in 80-90% of the patients, but since this was a renally compromised patients, CVD and others, so metformin were used only in 50% of the patients. Now we see 3-point MACE outcome here, and we can see it is neutral 1.02 parallel to placebo. Then secondary kidney outcome again 1.04, which was secondary, and A1C reduction was, since it was a equipoint, like so glycemic equipoint study, like we cannot have more difference in the. Still, there was 0.4, a small difference in A1C, 0.3%, which is justifiable. Like in any CVOT glycemia equipoise study, there we have only a less than 0.5% difference can be there at the end of the study. Now, extrapolatory findings in this trial were there was a reduction in albuminuria progression, as well as there was a reduction in composite microvascular endpoints. So this was, in addition to other beneficial effects. And there was no increase in hospitalization due to heart failure, hazard ratio 0.9. And here we can see hospitalization due to heart failure. Here we can see this A and B. There is a, no history of heart failure in these two. So this is basically, hospitalization due to heart failure here at the baseline. Now, this is hazard ratio 0.9, and this is a hazard ratio 0.88. Okay. So in this, there was no heart failure. In this, there was a history of heart failure. Still, we can see the difference in the hazard ratio is not much, and there was a beneficial effect. this was hospitalization due to heart failure with or without previous history of heart failure. Now, this is cardiovascular death with or without history of heart failure. This is without history of heart failure. This is with history of heart failure. And again, it is 0.95. So cardiovascular death also, there was no increase. In fact, there was a small decrease. So overall, like irrespective of history of heart failure, linagliptin was found to be safe as far as cardiovascular outcomes are concerned, as well as, there was in fact a small decrease in hospitalization due to heart failure. CARMELINA was another trial where linagliptin was compared with the sulfonylurea, glimepiride, and these patients are relatively new patients, like, very, very early stage of diabetes. It was only to see the safety and efficacy of linagliptin versus glimepiride, 6,050 patients. And overall, this trial was a very little long trial, 6.3 years median duration. And almost 42% had established CVD, 32% had 37 CV risk factors, 40% had diabetes less than 5 years. And basically, they were taking standard of care treatment for cardiovascular risk, and 9% were drug naive. And most of these patients were on metformin, 83%. So in this, again, CV outcome for both was, because early stage of, diabetes, I think all molecules are safe. And in terms of reduction in A1C and other, like it was found to be, both were found to be safe. In terms of hypoglycemia, it is very clear there was a high rate of hypoglycemia with glimepiride than lina. So this is an important thing to understand, that hypoglycemia is more common and it is quite severe in patients who are taking sulfonylureas as compared to DPP-4 inhibitors. Now, this is only lina versus glimepiride, and here it is like any kind of hypoglycemia or moderate or severe or hospitalization, also sometimes happen with hypoglycemia. So these are all, if we see with linagliptin, very, very less, and there's no hospitalization. So overall, to conclude, I would say that DPP-4 inhibitors are very important, anti-diabetic agents in a huge armamentarium of type 2 diabetes management. And after lifestyle modification metformin, they have a major role, important role, and these molecules are weight neutral. And there is some trials, in animal studies, GLP-1 have shown a preservation of, or rather rejuvenation of beta cells, and hardly any risk of hypoglycemia. Linagliptin have shown you the data of having proven cardiovascular safety. A single dose across all EGFR spectrum or all stages of CKD. There is a reduction in albuminuria as the disease progresses. So there is a relatively, protection from kidney disease, and there's no increase in risk of hospitalization due to heart failure. So these are important points, in favor of linagliptin compared to other gliptins. So with this, I conclude and I convey my thanks to all of you.
Thank you, sir. Thank you for sharing the details for linagliptin today with us. So there are a few queries from the audience. With your kind permission, can we proceed with the queries?
Yeah, we can.
Yes, sir. So, sir, the first query is, as a DPP-4 inhibitor, linagliptin is having only 2 CVOT trials. So how does this matter to you in your clinical practice?
Okay, so no, it's not a question of only one trial or 2 trial. It is basically, what is more important is how robust is the trial, okay, and what kind of patients were included in the trial. Now, okay, CARMELINA trial is the only trial among all DPP-4 inhibitors where there were renally compromised patients. Even patients, almost stage 4 and 5 were also included. And
yes,
the patients, almost 60% of them had CVD, 27% already had, history of heart failure. So this is a, severely compromised patients, high risk category where DPP-4 inhibitors have not been used. So okay, that way, the outcome, like in this trial, there was less progression of albuminuria or reduction in albuminuria, and it was found to be cardiovascular safe. So that makes this molecule more robust compared to other molecules.
Okay. And so next question is, what would be the benefit if we combine DPP4 inhibitors with SGLT2 inhibitors? Is there any clinical advantage?
Generally, I am not in favor of combining different, because then you are compromising with the fixed
Right, sir.
or dose. So, but yes, definitely some patients do require a combination, because suppose, a patient is taking metformin with DPP4 and we want to add SGLT2 inhibitor there.
Okay.
So, any fixed dose, then definitely the combination comes into play, but not straight away. Like enforcing that, from day one only you're starting. So, but that's definitely a combination is better in a way. It's more, better adherence and compliance. Instead of 2 pill, patient is taking 1 pill. And other is even some cost effectiveness, buying 2 different molecules, 2 different, packaging cost, other things, So the cost, the economical, as well as, adherence is better, definitely. But it's only, in category of people who require both the molecules simultaneously, and then we make it combination.
And sir, now there are so many DPP4 inhibitors available. So like vildagliptin, tenagliptin, and this linagliptin is there, and so many. So how will we segregate these molecules depending on the severity of diabetes or other comorbidities? Is there any criteria which you use in your
Can you repeat your question again? I couldn't get you.
Okay. So I'm saying, sir, in the DPP4 inhibitor family, there are so many molecules now. There is vildagliptin, there is linagliptin. So depending on the severity of the disease or the other comorbidity, do you differentiate with these molecules, or do you follow any principle for selection of these molecules?
Okay. They are very small and discrete, differences. Not much. Let me tell you, most of the DPP4 inhibitors, are almost the same.
Right.
The only problem is, yes, some DPP4 inhibitors don't have, CVOT trials. So like teneligliptin.
Yeah.
So there, and then sexagliptin, there was increase in hospitalization due to heart failure by 27%. So that also takes a little backseat, because most of the diabetic patients, they have CVD and they go into heart failure. Okay. Similarly, elogliptin also, there was almost 15 to 17% increase in hospitalization due to heart failure.
Right.
Vildagliptin, again, we don't have a CVOT trial, dedicated one. We have VIVID trial, which showed that in patients who were receiving vildagliptin, there was increased in left ventricular and diastolic as well as systolic volume. So, which was detrimental, in fact, negative, or it was against vildagliptin, even in VIVID trial.
Right.
So that way, if we talk of the true CVOTs, there, like now we have, say, sitagliptin, then linagliptin. They are relatively better molecules compared to other molecules, and no hospitalization due to heart failure.
Okay.
Coming to a renal compromisation, all gliptins can be used in renally compromised patients. Some gliptins do require a dose adjustment modification, while other gliptins don't require, like linagliptin does not require.
Right.
But again, not all gliptins have studies in renally compromised patients. So that's another important thing. Although, especially say teneligliptin, we don't have any data, so
yeah.
That way, so overall that, makes maybe linagliptin little ahead of others, because we have CARMELINA trial, which was basically dedicated, trial for renally compromised patients with CVD and previous history of heart failure. So that makes little edge of Lina over. So that's how we differentiate. But not all patients are renally compromised. So there we can't differentiate. I mean, try to understand. So depending on stage of diabetes, the patient's characteristics, and say vildagliptin, again, like for NAFLD, all are very good, but patients who have SGOT PT more than 2.5 or 3 times the upper level, then vildagliptin is contraindicated that way. So they all have a different metabolism. So we have to be very clear and have in-depth knowledge about all the gliptins and use accordingly.
Okay. Thank you, sir. Thank you for sharing your clinical expertise with us today. It was an honor for us On behalf of Macleods Pharmaceuticals, I thank you and all the doctors present in the audience for sharing your precious time, and especially you for sharing the experience which you have. It was really a very informative session for all of us. Thank you again, sir. We are definitely looking forward for having more such scientific sessions with you in future also. Thank you once again.
Thank you. Thank you. Thank you. Thank you, Ashwin.
Thanks.
Thank you, sir. So can I end the meeting with your permission?
Yeah.
Huh?
Okay. So
Yeah,
I'm
yeah,
ending
yeah.
this meeting.